Cristian García Herrera, cirujano oncólogo y hepatopancreato biliar, actualmente en el Instituto Nacional de Cancerología de México. Es para mí un gusto estar con ustedes el día de hoy. Gracias a la Asociación Mexicana de Hepatopancreato Biliar por la amable invitación para presentar la conferencia magistral del día de hoy, la cual será impartida por el doctor Mark Truty. Como todos saben, el doctor Truty es un distinguido y por demás sobresaliente cirujano oncólogo y hepatopancreato biliar en la Clínica Mayo en Rochester, con una gran experiencia y reconocimiento en el manejo de tumores pancreáticos, hepáticos y biliares, entre otros, quien ha enfocado su práctica clínica y de investigación en desarrollar abordajes novedosos en el tratamiento de estos tumores, con el objetivo de mejorar los resultados clínicos en los pacientes que lo padecen. Específicamente ha aportado información nueva y muy relevante en estrategias para poder tratar quirúrgicamente tumores que otros cirujanos consideramos irresecables. Sin más por el momento, los dejo ante la distinguida presencia del doctor Truty con su conferencia magistral. Buenas tardes.
Hello, my name is Mark Truty. I'm a surgeon at the Mayo Clinic in Rochester, and it is my privilege today to talk to the Mexican chapter of the AMHPB. I had the honor of giving a talk last year to the group talking about arterial resections in locally advanced pancreas cancer. I've been asked to give another talk today, specifically entitled Pancreas Cancer from Bench to Bedside. And today I'll be talking about some recent advances that we've been pursuing at our institution to help improve the outcomes of this special subset of patients. So thank you for having me. If cancer is the emperor of all maladies, then pancreatic cancer must be the emperor of all emperors, because it remains the least survivable of all malignancies. And this dismal statistic has not changed in decades. Fortunately, it's not a particularly common cancer. In the United States, last year, about 58,000 patients were diagnosed, half of whom were already obviously radiologically metastatic. 1/3 of patients present with traditionally unresectable disease. We now refer to these patients as borderline or locally advanced, leaving behind a small subset of patients whose tumors are localized to the pancreas and we deemed resectable. And hence the term resectability and the problem with surgeons. With one surgeon deeming a patient resectable, that patient is pushed to the operating room for better or worse. And another surgeon may deem the same patient unresectable, potentially denying a life-preserving operation for that given patient. So what is our role as surgeons in the management of a pancreas cancer patient? Well, it's to provide a reasonably safe and an effective operation. The operation should be potentially curative. We need to focus on the importance of a margin negative resection, one of the few things we do have level 1 data for. And the only thing we can really control in the operating room is to prevent local recurrence, which has historically been unappreciated, but as patients are living longer, this is likely to become a future surgical quality indicator. Now, many surgeons have dedicated their careers to create these radiologic resectability classification systems based on modern cross-sectional imaging, which can highly predict major vascular involvement. And there's a whole variety of these. They're all similar in terms of describing degrees of venous or arterial involvement. Interestingly, this is unique to pancreas cancer only. There's no tumor type that has such specific designations. And we're all familiar with the resectable, borderline, or locally advanced terminology. Now, these systems were based on two critical assumptions. They were developed only to predict margin risk in those patients who underwent upfront surgery, meaning no neoadjuvant therapy, and in patients who underwent a standard anatomical plane-based techniques, meaning no extra anatomic vascular resection or reconstruction. In the absence of one or the other, in the modern era, these systems are completely useless. So why is that? What has changed? Well, we're all aware of the development of effective chemotherapy in the last decade. We used to have single agent drugs with poor response rates. And in 2011, and then a couple years later, we saw the development of FOLFIRINOX and Gemabraxane, and we saw significant responses and survival in the metastatic setting. And we rapidly adopted these agents in the neoadjuvant setting for more advanced tumor types. We're also starting to appreciate the potential benefit of preoperative chemoradiation, and we may argue over which modality is optimal, the purpose of which is to target the tumor as well as the surrounding at-risk structures. And many will argue, well, there is no direct survival benefit to preoperative chemoradiation, but there is level 1 data that those patients who undergo preoperative chemoradiation do have a significant decrease in their margin positive rates as well as their node positive rates, and thus there is likely an indirect survival benefit. And finally, we've just technically become, better surgeons. We've taken techniques from other cases such as liver resection or sarcoma, and we're more comfortable with unblocked vascular and multivisceral resection. We're learning how to identify and mitigate post-pancreatectomy complications, as well as better manage the consequences for the patient in terms of the multivisceral resection. So as a result of these advances, we've become more surgically aggressive, specifically with arterial resection. And at Mayo Clinic in Rochester, we have the largest US experience, over 200 arterial resections for pancreas cancer, a lot of hepatic arterial resections. We have the world's largest celiac axis series, as well as SMA. Tumors can involve the hepatic artery or replaced hepatic vessels. They can involve the superior mesenteric artery or the celiac axis. They can also involve any combination thereof. Thus, we've been able to create a whole new set of operations limited only by our creativity and technical feasibility. So let's talk a few of these. Hepatic artery only resections. We could resect the common or proper, a replaced right or a replaced common off the SMA. They can be straightforward with a segmental resection and end-to-end anastomosis. They may require some form of arterial transposition, and in many cases require a formal interposition graft. Historically, either saphenous vein grafts, we're using more autologous grafts, either splenic artery or SFA, and are also using a lot more of cryopreserved cadaveric grafts for these reconstructions. Tumors that encase the SMA need a segmental arterial resection and revascularization. The further down you go on the SMA, the more jejunal branches are involved and the greater the bowel resection. My typical relative distal limit is the origin of the middle colic artery, as anything beyond that typically results in a more extensive bowel resection, risk of colonic ischemia, and those patients will likely have significant malabsorptive issues. We also need to assure a patent IMA as a retrograde perfusion in case there's a problem with the SMA graft. Tumors can involve the replaced hepatic vessel coming off the SMA. These patients require dual SMA and replaced vessel resection with a more challenging reconstruction to both the liver as well as the viscera, oftentimes with the venous resection and reconstruction. Tumors can involve the celiac axis proper. If a patient has adequate collaterals, they can go and undergo an unblocked celiac axis resection, relying on those PDA collaterals to perfuse the liver. And those patients who do not have adequate collaterals, they will require formal hepatic arterial reconstruction. And the key for these cases is whether or not you can preserve the stomach. And you need to make sure you have adequate gastroepiploics as well as a dominant right gastric artery for gastric preservation. Tumors can involve the celiac and extend laterally beyond the GDA and proper hepatic artery. In these patients, the stomach cannot be preserved. They require a formal celiac hepatic artery resection. If the tumor does not involve the pancreatic head or bile duct, a subtotal distal pancreatectomy can be performed. If it does, then a total pancreatectomy. All patients receive hepatic arterial reconstruction, total gastrectomy, and a Roux-en-Y esophagogigidostomy. Tumors can involve the celiac and extend inferiorly to involve the proximal SMA. These patients can undergo a subtotal distal pancreatectomy, celiac SMA with dual arterial reconstruction. We used to do these Dacron grafts. We've moved away from those because of infectious complications, and now we use more cadaveric bifurcated grafts. And the most extensive of cases, tumors involve the celiac, extend laterally to the proper, extend inferiorly to involve the SMA, oftentimes with portal SNV involvement. These patients require celiac, hepatic, SMA, portal vein resection, total pancreatectomy, total gastrectomy, complex venous arterial revascularization, as well as dual rule limb reconstruction to the bile duct and the distal esophagus. What are the limits? Well, these are very difficult, as you can imagine. They're truly custom and bespoke operations for any given patient and their anatomy. Each vessel involved has 2 points of fixation. So the more vessels you have to deal with, there's more points of fixation intraoperatively, and the order of the operation becomes more complicated. We're operating in non-anatomical planes. These cases do have increased risks compared to standard cases, primarily hemorrhagic, ischemic, and the most deadly are infectious complications. Our mortality has significantly improved over time to 4% 90-day over the last 75 cases. But because of these risks, they're only appropriate in selected patients after effective therapy. So what do I mean by this? As our operation becomes greater in magnitude, so do the operative risks. And in order to justify those risks, we need to balance them against the predicted oncologic benefit. And so how we do that is sort of the focus of these next few advances we're going to be talking about. And there's 3 main categories. We're going to be talking about new techniques to identify occult metastatic disease. We're going to be talking about what we're doing to minimize infectious complications after pancreatic head resection. And then finally, focusing on how do we maximize our neoadjuvant chemotherapy benefit and assess responses. So we'll start with the first. One thing we're all familiar with is that there is a subset of patients who will recur and die, up to 25% of those, within 12 months of a seemingly curative operation. These patients are plagued with either hematogenous metastases, liver or lung typically in 2/3 of cases, and another third of patients with peritoneal dissemination or some combination thereof. Now, historically, we've used tumor markers, to predict the biology, such as CA19-9. Let's talk a little bit about CA19-9. It's used for a variety of malignancies, initially described for gastric cancer. It has a mechanism. It is a ligand for endothelial cell selectin. Thus, patients with a high CA19-9 have a high predominance of hematogenous metastases. It's not a good screening tool because 10% of patients lack the fucosyl transferase necessary for expression, and they're non-secretors. 1/3 of people present with normal levels, and we know that CA19-9 can be elevated in jaundice patients or those with biliary inflammation. We know that CA19-9 elevation is associated with worse survival, and every major center has published their cutoff, but it's often ignored. Then this paper came out. It was very simple, very elegant paper out of Germany. Everyone underwent upfront resection, and they stratified their survival solely based on their CA19-9 at diagnosis, regardless of their bilirubin level. And as we can see how beautifully this stratifies, the higher the CA19-9, the worse survival. Those with greater than 1,000, less than a year. So currently, I have very high CA19-9, meaning over 1,000. That's pretty much consensus criteria globally for neoadjuvant therapy. But what about if your patient is less than 1,000, but it's above normal, sort of that middle ground? What do you do in those patients? What about patients with big bulky tumors? Does that explain the high tumor marker? What about patients that are jaundiced, like many are? How do you interpret a CA19-9 in those patients? So we looked at that specifically. We looked at our early data of upfront surgery, and we found that the majority of those patients did have sort of that middle ground CA19-9 level. What we interestingly found was that CA19-9 did not at all correlate with the serum bilirubin or the tumor size, much in contrary to our initial beliefs. The only thing that CA19-9 correlated with was survival after surgery, meaning those with any elevation of CA19-9 did significantly worse than those that had a normal or who were non-secretors. Now, these graphs look very similar to this graph. This was a famous paper by Carl Bilmoria, one of my co-fellows. When he was a resident, he looked at the NCDB database. He was one of the first physicians to be able to have access. And he looked at all early stage, meaning those that were less than 2 centimeters, clinically node negative pancreas cancer in the United States. And he found those early stage patients, only 28% of which actually underwent pancreatectomy, with a survival of about 19 months, which seems pretty standard. 72% of patients did not undergo surgery despite being early stage, and the median survival of those patients was only 8 months. The conclusion of this paper was that we needed to operate more on these patients. That's one conclusion. The other conclusion is that if this is really early stage disease, why are those patients only alive for an average of 8 months? There must be something else that we're not measuring. So we specifically redid that study in 2016. We looked at the National Cancer Database. We looked at over 100,000 patients of all stages. We wanted to see how often CA19-9 was even measured. And we looked at survival in 3 cohorts: non-secretors, patients with a normal CA19-9, and those with any elevation above normal, regardless of extent. What we found pretty much surprised us. First of all, only 25% of patients in the United States even had a CA19-9 level drawn. It's a less than $100 assay. That was quite shocking. We found that non-secretors did as well as those patients with a normal level. And we found that patients with any level of CA19-9 elevation, regardless of how moderate or large, there was a stage for stage worse survival. And the largest detriment was actually in those patients with localized tumors undergoing surgery. And in those patients who did, they had a nearly 50% reduction in their survival, as bad as a positive margin. We then wanted to see what was the optimal treatment sequencing in these patients. And after factoring in everything else, including margins, lymph nodes, etc., we found that those patients who only had surgery, not surprisingly, if the high CA19-9, they did worse. Even those that received adjuvant chemotherapy, there was still a detrimental benefit to that high CA19-9. And the only treatment sequencing that abrogated that hazard risk of CA19-9 elevation was neoadjuvant chemotherapy. And we also did this analysis on an intent to treat, whether or not they actually underwent surgery. And this was our final analysis of all patients with an elevated CA19-9. The best survival was seen in those patients undergoing neoadjuvant chemotherapy, even on an intent to treat analysis, better than surgery followed by chemotherapy. So CA19-9 is good, but it's still not great. Is there anything else we can do? So we know that the majority of pancreas cancers harbor KRAS mutations. And logically, a non-metastatic patient should not have circulating mutant KRAS DNA in their blood. Well, in 2018, Mayo developed a clinically available peripheral blood test. This is a digital droplet PCR liquid biopsy test that measures a whole variety of KRAS assays. Initially, this was developed for colorectal cancer, and I rapidly adopted this into my practice. This test is both qualitative, meaning it's either a negative or positive test, and in those patients who are positive, it's also quantitative. It gives you the copy number per mil. And so we performed a 350 patient prospective trial of all patients referred to our surgical department with seemingly non-metastatic pancreas cancer based on their outside scans. All patients underwent mutant peripheral blood KRAS testing. They all underwent full staging at our center with a triple phase CT, PET scan, which is routine, we'll talk about later, and a staging laparoscopy. Of those 350 patients, 22 or 1 in 5 were found to have a positive mutant KRAS in their blood, with a median of 20 mutant KRAS copies per mil of plasma, and you can see the wide range here in this graph. We did find that mutant KRAS status associated with several things. Those that were positive mutant KRAS did have a higher median CA19-9 level, but the overall proportion of those that were CA19-9 elevated was no different between groups. Those patients, after full initial staging at our center, twice as many were found to have metastatic disease if they had a positive KRAS. Of those patients that didn't have metastatic disease and went on to neoadjuvant therapy, another twice as many patients developed metastatic disease on neoadjuvant therapy, with the overall metastatic development of 74% in a positive KRAS patient versus 41% in a negative KRAS patient. And we also found nearly double death of disease progression if they were KRAS positive at diagnosis. We found that the quantitative levels also mattered. Those patients with a higher copy number were more likely to ultimately develop metastases compared to those with lower copy levels. We then compared this to CA19-9, and we found that mutant KRAS status was far more specific, was more predictive, and had a higher likelihood ratio than an elevated CA19-9 level alone. And thus, KRAS status was more specific for metastatic disease. More importantly, this was also beneficial in those patients where CA19-9 was not helpful, either those that were normal or non-secretors. And as you can see here, a significant portion of the positive tests also had metastatic disease that would not have been predicted by a CA19-9 because it was not evaluable. And despite a very short follow-up, we were still able to show a significant difference in progression-free or overall survival solely based on KRAS status. Now, because the blood test was so predictive, we wanted to see, can we use the same assay in the peritoneum? As we know, a significant portion of patients have occult peritoneal disease. And so we have an ongoing prospective trial. I'll show you some results of a little over 200 patients for which we have completed data. This is a modern prospective trial. All patients with radiographically non-metastatic disease at our center underwent recent staging laparoscopy with peritoneal lavage and cytology. All the peritoneal lavage fluid was sent for a mutant KRAS, for cytology, as well as for peritoneal fluid CA19-9 and CA levels. We defined a clinically positive laparoscopy as either gross carcinomatosis or those who had positive cytology. In this modern prospective staging laparoscopy trial, we found 23% of patients had clinically positive disease, okay, much higher than people would have thought in a modern era. It was either gross disease in 36 of 52, cytology positive in 29 of 52, and a combination of gross disease and cytology in 13 patients. Interestingly, of those with gross disease, only 1/3 of which had a positive peritoneal cytology, which shows you how poorly sensitive cytology is alone. A positive cytology is good, but a negative cytology does not rule out peritoneal disease. When we looked to see if we could detect mutant KRAS mutations, we found 65 of these patients, or 29%, had positive mutant KRAS mutations in their peritoneal fluid. And most importantly, this highly correlated with clinically positive disease on laparoscopy. There was also a quantitative predictive value. Those patients with higher mutant KRAS numbers were more likely to be clinically positive, as shown here on this graph. When we looked at peritoneal fluid tumor markers, which is something we've recently been doing, we found that 1/4 of patients had elevated CA19-9 in their peritoneal fluid, and this also correlated with mutant KRAS. Similarly, 11% of patients had elevated CA in their peritoneal fluid, and this also correlated with mutant KRAS in the peritoneal fluid. Thus, in conclusion, it appears that using cell-free mutant KRAS DNA appears to be predictive of occult metastatic disease at presentation. We get a peripheral blood assay to predict hematogenous metastases, and we do a peritoneal fluid assay to predict peritoneal dissemination. And this is now routine prospectively for all surgical patients at Mayo Clinic. We are now trying to expand this, looking at other markers in addition to KRAS to see if we can increase the sensitivity and specificity of these assays in the future. Going to be switching gears here a little bit, talking about surgical complications. All of us are aware of the considerable risk of surgical site infections after pancreatic head resections. About 1/3 of patients, despite our typical 24 hours of empiric prophylactic antibiotics. We do know that bacteriobilia is very common in patients undergoing pancreatic head resection due to previous instrumentation or stenting, and the organisms in that bile are typically a driver of the subsequent SSI. As a result, many centers have moved to performing intraoperative bile duct cultures and extending the duration of their empiric antibiotics, and then tailoring those antibiotics based on those bile duct cultures. And this strategy has been shown to decrease surgical site infections. Now, what's the ideal test for such cultures? Well, ideally, we want it to be rapid turnaround because we want to know whether they're positive or negative and what they are early, so we're not treating inappropriately. We want these cultures to be sensitive and specific, and we want them to be cost effective. So one of the first things that we did is we modified our practice and moved from typical swab cultures to formal aspirations to get a liquid specimen. This allows us to get both anaerobic as well as aerobic speciation. This yielded higher organisms, more fungi. And because it's a liquid sample, it allows for a new technique which is metagenomic analysis with nanopore sequencing. So what am I talking about by that? I'll slowly explain. So microbiome nanopore sequencing uses this GridION sequencer, where we take DNA that's extracted from a liquid sample. The host human DNA is depleted. The microbiome DNA is then enhanced and sequenced and then characterized using known sequencing libraries. And so using this new technique, which was developed here, we decided to do a pilot study. So about 42 patients who were undergoing pancreatic head resection, all of whom had intraoperative bile aspirates. Half of that aspirate was snap frozen, sent for microbial DNA isolation and nanopore sequencing. The other half of that bile aspirate underwent standard cultures, as is our current protocol. And then we compared standard cultures to the nanopore sequencing results. So what did we find? Of those 42 patients in the standard cultures, it was about 50-50. Half the patients grew something, half the patients did not. It was identical in the microbiome sequencing. So for one, it was an absolutely perfect correlation between both techniques. What's the difference? Standard cultures took about a median of 4 days to complete before we got the organisms and the sensitivity data. Nanopore sequencing allowed this data within 8 hours, and that was very significant. We found that the sequencing data had a higher average organism yield of 10.5 versus 4.4 versus standard cultures. And most importantly, it identified a higher number of resistance phenotypes compared to standard cultures. When we looked at cost, standard cultures, about $38. Nanopore sequencing was nominally more expensive at about $165. However, we found significant possibility for cost reduction because, as I told you, 48% of patients ultimately had negative standard cultures. We would have known that within hours with the sequencing results. And thus 48% of patients were receiving prolonged antibiotics that were totally unnecessary. And thus we could have had our cost savings by just stopping those antibiotics at that time. And thus, in conclusion, for bile duct cultures are important for patients undergoing pancreatic head resection. We found a new technique of microbiome DNA sequencing is not only feasible, it results in answers in hours, not days. It's perfectly correlative with growth in cultures, has a higher yield, broader microbial data. It's nominally more expensive, but it can lead to cost savings due to improved antibiotic stewardship. And we have a current prospective trial underway to compare these. Be switching gears again and talking about neoadjuvant chemotherapy and how to optimize things and assess response. So all of you understand the importance of neoadjuvant chemotherapy for borderline or locally advanced disease. No regimen has demonstrated superiority one over the other, FOLFIRINOX versus Gemabraxane. The choice is typically dependent on a variety of factors or preferences. The role of this is to identify patients who'd benefit from surgery. We're hoping that we're treating occult metastases, and some patients we may potentially downstage to resectability. And in the end, we're hoping to increase survival. Well, to achieve these goals, we need to demonstrate objective responses with acceptable tolerability. So how do we assess patients after that initial round of neoadjuvant chemotherapy? Well, we could look at clinical responses, we could look at radiographic response, we could look at biochemical response, and in our center, we're looking at metabolic response, which we'll talk about shortly. So in our practice, like all others, everyone is seen and evaluated. They all get these tumor markers. They all get cross-sectional imaging. We use a lot of PET imaging. Everyone undergoes first-line chemotherapy. Those patients who return without metastases on their first restaging, at our center, if they're tolerating it and they're showing signs of response, we continue that same line of therapy. If they're showing toxicity or they're having non-metastatic progression or no response, we do chemotherapy switch, which is something we first described in 2018. And we're going to be showing you the results of a paper that just got published of our overall experience. This includes 468 patients with borderline or locally advanced pancreas cancer that underwent neoadjuvant chemotherapy and returned with their first restaging with no metastatic disease. So that's the cohort. Of those patients, 70% of patients went on to receive additional first line and underwent surgery, whereas about a third of patients required chemotherapy switch. What were the reasons for switch? Well, about 40% had non-metastatic radiologic progression. 40% had CA19-9 that rose. 25% had no responses, meaning a stable tumor marker, stable PET, stable CT. 20% had toxicities or intolerance to first-line therapy, and about a third of patients had any one of these indications. Of those 139 patients that underwent switch, about a third were ultimately not resected. The majority of due to metastatic disease after switch, or anatomically unresectable disease after switch, or performance status that did not allow resection. And thus 72% of patients were able to achieve responses and undergo resection after chemotherapy switch. When we looked at all the surgical patients, again, we have two groups. We have the 77% of patients who underwent resection after first line, and then this should be 23% of patients who were resected after chemotherapy switch, and we compared them. We found no significant difference in demographics, no difference in the ultimate CA19-9 normalization, no difference in need of vascular resection, either venous, arterial, or both, no difference in major morbidity or 90-day mortality. Similarly, found no difference between groups in terms of margin positivity, positive lymph nodes, pathologic treatment response, recurrent disease, or death at follow-up. In this group, there were only two predictors of survival, similar to what we had previously published. CA19-9 response was predictive, as well as was pathologic treatment response. When we looked at recurrence-free survival, there was no difference between first-line patients or chemo switch patients. And then overall survival, similarly, no difference in first-line versus chemo switch that underwent resection. Those patients who underwent chemo switch but did not undergo resection, they did significantly worse with a median survival of less than 20 months. So in conclusion, 1/3 of patients may require chemotherapy switch, likely due to no objective responses or toxicities. In our experience, a high proportion of patients can be salvaged with this strategy with no oncologic detriment. It allows for optimal treatment sequencing and may improve outcomes for these more complicated patients. We'll move on to my final aspect of my talk. This is a question I give to all my trainees. If they had pancreatic cancer, which neoadjuvant chemotherapy or treatment would they want? Would they want 6 months of chicken McNuggets or 6 months of IV chemotherapy? Now, they all think I'm joking when I ask this, but I'm actually quite serious. And they invariably, say, I'll pick the chemotherapy. And I told them, well, actually, it depends, because it's not about receiving neoadjuvant chemotherapy. It's about receiving effective neoadjuvant chemotherapy. So how do we know what we're giving the patient is effective? Well, we're going to use our 3 little piggies here to demonstrate this. So our first little piggy strongly believed in radiologic response because we use it for a variety of other tumor types. So what's the data for radiologic response in pancreas cancer? Well, radiologic downstaging is so rare, specifically for locally advanced pancreas cancer, that it's actually a myth. Tumors that encase arterial structures do not at all pull away, ever. Resist responses do not associate with path responses or survival. And this data is so strong that neither the NCI nor the NCCN considers radiologic downstaging as a clinically relevant endpoint. And thus our first little piggy did not do so well. Now our second little piggy, she was a little bit more clever, and she said, you know what, we're going to use CA19-9. That's really important. And she's correct. However, as I told you, 10% of patients are non-secretors. 1/3 of patients have a normal CA19-9. Thus, a large fraction of patients, it's completely useless. In that 60% of patients where we do have something to follow, we're still arguing what's the optimal decrease. The NCCN suggests a 50% decrease. So if I went from 4,000 to 2,000, I should do a celiac resection? That's crazy. Others have suggested a higher threshold. Our data and others have suggested it needs to normalize. But when does it matter? Does it matter when? Does it matter after chemotherapy it normalizes, or whether after chemoradiation? It probably does, because either of those probably has different prognostic implications. So although our second little piggy was onto something, ultimately it failed for a large proportion of patients. And we're left with our last little piggy. Now, he was particularly bright, and he said, I want to look at path response. And everyone kind of laughed at him. They're like, what are you talking about? And he said, well, listen, when I looked at all the neoadjuvant papers, I found that, vascular resection was not at all in and of itself detrimental. And the only thing that was predictive in all of these papers was subsequent path response. However, path response is a postoperative metric. Okay, and our own group has also found that major path response was the single largest predictor of survival. But so how do we predict path response preoperatively? Well, that's where our practice has dramatically changed over the last several years, in that our significant use of PET scans, either PET-MR or PET-CT. And we have found that metabolic response highly correlates with pathologic response, and that is superior to CT or CA19-9 responses alone. We have a paper we've recently submitted looking at our extensive experience, and we found that the metabolic response on PET had a higher diagnostic accuracy in predicting path response compared to biochemical response assessment alone, with a higher sensitivity, higher specificity, higher predictive values, and higher likelihood ratios. And when we performed our Cox proportional hazard analysis for both recurrence-free and overall survival, major metabolic response was the only predictive thing for recurrence-free survival and overall survival. On multivariable analysis, we found that metabolic response was the only preoperative factor with the single largest predictor of survival, meaning those patients that achieved a complete metabolic response had a nearly 70% 5-year survival versus those that still had metabolic activity. Why is that? Because a dead primary tumor likely equals dead systemic disease from that chemotherapy. And thus our final little piggy appears to be onto something, looking at path response, but because we don't know that preoperatively, looking at metabolic response, at least until something better comes along. So in conclusion, we know that surgical options exist for these anatomically advanced pancreas cancers, and arterial resections are now going to likely be more commonly performed at major centers. But in order to consider such, we need to adequately select these patients. We need to start focusing more on molecular diagnostic staging at initial diagnosis to identify patients who are at risk of metastatic disease. We need to understand the importance of bile duct cultures in patients undergoing pancreatic head resection in order to optimize antimicrobial therapy to decrease complication rates. We need to consider chemotherapeutic switch after first-line neoadjuvant chemotherapy, particularly in those with toxicities the first line or no responses. And we'd highly recommend all patients undergo a baseline PET and using metabolic response objectively, serially, to assess neoadjuvant chemotherapy response and survival to determine subsequent surgical candidacy. Thank you very much. It was absolutely my pleasure to present to the group today. I'd be happy to answer any questions.
Much for your excellent talk. Like always, Dr. Truty, very interesting, pretty interesting points, very current points of view covered in this talk in very short time, and very pretty concise and very elegantly. We will now start the discussion session. For this Q&A, we also have Dr. Jorge Roldan, who is a hepatopancreatic biliary surgeon. He is working in the University of Emaquil in the oncology division. Dr. Jorge, would you like to say something, sir? Would you like to ask a question to Dr. Truty while the audience is sending their questions? Go ahead, Dr. Roldan. Yes, thank you, Sebastian. Thank you very much for participating, Dr. Mark Truty. Quite frankly, your talk, in just a little bit of time, you were able to give us a lot of good information, and I think it will be very useful to take in all these points. Doctor, I would like to say something. I would like to revisit something from your talk, and that is how to assess the response of patients that are sent to chemotherapy, given that the CT will not always be as useful to provide you a response regarding the tissue. And we know that some of these patients are non-secretors, some CA19-9 non-secretors. I know that now they're starting to recommend PET scan. I would like to ask you, so for Latin America, you see, it is somewhat difficult for us to do PET scan as first line and then trying to compare that after chemotherapy. That may be an issue. What is your appreciation about regarding this? And the follow-up question to that is, what is the role in this specific scenario? What role would you give the staging laparoscopy procedure? Go ahead, over.
So I'll start with the second question first. So in our practice now, we've now routinely moved to undergoing staging laparoscopy in a significant portion of patients. And so therefore we have to make a decision. Are we going to consider a resection or we're not? And the same thing happened here. I wanted to do all these arterial resections. I had to have some guarantee that this patient would do better. And therefore the only thing available to me was PET scans. We started with PET CTs. Now we're using a more sensitive PET MR. Even in the United States, we're still the only center that routinely uses it. So I'm trying to get this approved by our insurance providers, because right now, some data we just are submitting now, it's the only predictor preoperatively of path response and survival. And if we're going to be considering taking patients to the operating room with more extensive operations and therefore greater risk, we have to justify those risks with the predicted benefit. And if we're still just using a tumor marker and a traditional CT scan, in my opinion, that doesn't justify those risks. So we need to push on the insurance providers, whether that's commercial or whether it's a government provider, to cover such imaging if we're going to really push the envelope in this disease.
Doctor Truty, yo tengo otra pregunta en relación.
Dr. Truty, I have another question now regarding the use of CA19-9 as a surrogate for metastatic disease in patients with a CA19-9 elevation. Sorry, his audio is coming in choppy. And when we decide to go for neoadjuvant therapy, you mentioned it very well, sir. It is not established how to assess the CA19-9 or the response to CA19-9. Wait for it to normalize or use percentages, different percentages. Different guides give you different recommendations. In your experience, what is an appropriate response or optimal CA19-9 response post-chemotherapy, and what to do with this subset of patients where we have already finished neoadjuvant systemic therapy and the CA19-9 is not normalized and they continue to have it elevated? These are patients, should we leave them with chemotherapy, or should we take them through more cycles until they go normal? Or are they patients where we should possibly explore surgically since there is no progression of the disease? Over.
Yeah, so there's growing data. You know, initially we used to say 50%. Another paper said we need an 85%. You know, something really specific like that. There's growing evidence that it needs to normalize. That is the optimal, and that group of people who are elevated to begin with. We need to make sure we've ruled out other benign causes of CA19-9 elevation. Make sure their stent is well drained, you know, etc. If we cannot normalize it with first-line chemotherapy or by extending first-line chemotherapy, you know, our approach is we need to consider chemotherapy switch, because we know if we operate on a patient with a persistently elevated CA19-9, those are the patients that have a higher proportion of earlier recurrence. If we still cannot normalize the tumor marker despite ruling out benign causes, despite chemotherapy switch, and despite extending duration of chemotherapy, then you're left with an honest discussion you have to have with that patient, knowing that this patient is probably not going to have the best outcome. And therefore we have to say, well, what operation am I going to be offering? Is it a laparoscopic or robotic distal pancreatectomy, which anyone can get through with low complications? Or am I considering a celiac resection or something that has a greater impact on that patient's quality of life? And then you have to have an honest discussion. Some people say, well, let's do radiation and see if it normalizes. Now, it may normalize with radiation, but the prognosis of CA19-9 normalization with radiation versus chemotherapy is probably different, because radiation is local regional treatment and chemotherapy is systemic, and we want to see the response to systemic therapy. So yes, in a patient who's otherwise resectable with relatively low morbidity, I still don't see a reason why you would not offer an operation, but you have to understand, and the patient needs to understand, it may not be a perfect outcome that we're all hoping for.
Y un poco en relación
And a little bit on the chemotherapy switch, when you compare the results between patients that have an appropriate response to first-line chemotherapy and the oncologic results in patients that underwent this switch, we see there is no survival, overall survival numbers or progression-free survival. So we're not sure about the right chemotherapy in these patients, and it seems to be a flip of a coin whether we would go for that choice. So what progress is there on molecular genome studies in order to identify what tumors will respond initially, or what tumors will respond initially to nab-paclitaxel with gemcitabine, trying to stay away from the toxicity in a chemotherapy that can be unnecessary for that specific patient? Over.
Yeah, so, you know, unfortunately, we only have two real regimens that have really demonstrated response. And there is no real hard data to suggest one is better than the other. Oncologists typically, you know, they tell patients, oh, FOLFIRINOX is much better and stronger, but those are based on metastatic trials, and they were never compared head to head. We do have a recent SWOG trial where they did give patients either FOLFIRINOX or gemabraxane in a randomized fashion, and that showed no difference. And so in our practice, it's basically, like you said, it's a flip of a coin. In general, it's a lot easier to take a patient to start with FOLFIRINOX and then switch them to gemabraxane than to start with gemabraxane and move them to FOLFIRINOX. You know, that's a little bit going uphill. So that is our pretty much standard approach, although some oncologists prefer gemabraxane initially. Some cancers respond to FOLFIRINOX, other cancers respond to gemabraxane. Lucky patients have a tumor that responds to both, and unlucky patients don't respond to either. So there is a lot of work, you know, trying to figure out, can we predict which chemo to choose? There is some looking at a basal type phenotype in pancreas cancer that would suggest a better response to FOLFIRINOX as opposed to a platinum agent versus others. I think that data is still too preliminary, and it hasn't necessarily been able to be as accurate as we hope. I'm hopeful that in the coming future, in the next couple of years, not only will be able to predict which chemotherapy will be effective, but hopefully we'll have more than 2 options, because 2 options, it's better than no options, but we want something like 6 options like we have now for colorectal metastases.
Perfecto. Y
Perfect.
un poco continuando con este tema.
And just to cover a little bit more on this topic, when is the right time in order to assess or restage a patient and determine whether there is an objective response to first-line chemotherapy? After how many cycles? I understand that each group that is adopting this approach, each group has its own preferences, but based on your experience, when is it a right time to reassess whether we are providing an efficient neoadjuvant therapy for these patients? Over.
That's a great question. I think it varies from practice to practice. Typically, it's anywhere from 2 to 3 months of therapy. I tend to favor the 2 months of chemo, 4 cycles of FOLFIRINOX, or 2 full cycles of gemabraxane, on a 3 on 1 off kind of protocol. You want to know early whether or not you're having a response, or more importantly, you want to know early if you're not having a response, because you don't want to subject that patient to the toxicities with no clinical benefit. I'm hopeful that in the coming future, I talked about the cell-free KRAS assay, that we'll find more molecular markers that we could measure in the blood that are quantitative, that hopefully by simply taking a blood test, we could see a marked drop in one of those markers within a week or 2 of treatment. And if we see that, we're on to something, we continue. If we're not seeing that quantitative change, then hopefully we can then switch to something else. But right now in our practice, I say 2 to 3 months of treatment, no later than that. But again, this is still relatively, early on.
Y bueno, un poco una pregunta obligada.
And this is, I guess, a given, asking this question based on all the work you've published. The results on patients with pancreatic cancer, borderline or locally advanced, and they undergo this systemic neoadjuvant therapy, all these protocols, and then radiotherapy, along with concomitant therapy, and eventually resection. The negative margin rates, you reported great numbers. Do you believe that this is because of the neoadjuvant therapy all by itself, or do you think this is because of these aggressive block resections with all the, with all the structures that are at risk with R1, or is it a combination of both? Over.
I would probably suggest it's a combination. We do know that those patients who undergo neoadjuvant therapy, now you could stratify that into chemo only or chemotherapy followed by chemoradiation, the margin negative rates tend to be lower. In our practice, we definitely do a more unblock resection, not just of the tumor, but of the at-risk tissues. So we differ significantly from the Germans, who are now proposing doing these divestment procedures, where a tumor involves an artery and they peel it off the artery. The data we have, if you look at the Johns Hopkins experience, they published a paper on all of Dr. Cameron, Dr. Cameron, famous pancreas cancer surgeon, all his local recurrences. 90% of his local recurrences were within 2 centimeters of the origins of the celiac and SMA for tumors that did not involve the celiac or SMA. Meaning, although we think we're doing a very good technical operation, we're likely leaving behind a lot of occult disease, because the difference in pancreas cancer, and the pathologists have known this for decades, it's microscopically infiltrative away from the main tumor. And that's why you could look at a patient who has an obviously localized tumor on the CT, far away from all vessels, and you operate and you still end up with a positive margin. Like, how did that happen? It's because it's infiltrative away microscopically. And so because of that fact, we do have a more of an unblocked resection. That, I think, combined with some chemotherapy response, with some sterilization with radiation, I think that's where we get this better negative margin rates.
Muchas gracias. Creo que estamos en tiempo. Jorge, no
I
sé.
think we are doing good on time. So Jorge, do you have any questions? Do you have any comments? Anything else? Jorge says, yes, I would like to add a next and last important topic that is worth mentioning for our audience. More and more you have groups and hospitals that are starting to use neoadjuvant chemotherapy in patients with localized resectable disease or upfront resectable, like we can call them. And I would like to ask Dr. Truty, since we have him here, what is your institutional decision on these patients? What is your view on this? Over.
So it depends on what is your indication for neoadjuvant. Now, when we talk about, borderline, those are typically anatomic issues, okay? But we also have patients who have borderline biology, patients who have borderline condition, and most patients have some combination of anatomy, biology, or condition. They're not mutually exclusive. And in most patients, if you really look hard, you could probably find some, risk factor that would make you choose neoadjuvant, whether it's you're concerned about a margin, the tumor marker's high, you have some indeterminate lesion on a scan, they have some poorly controlled diabetes, their nutrition is poor, another reason why they shouldn't do well with an upfront resection. We do know with great detail what the outcomes are for an upfront surgery. Go to your local cemetery. You'll find lots of patients who had a successful upfront operation. Okay, we know that the benefit of surgery is about 20 months on average. Now, everyone hopes that they're the patient who doesn't have occult metastatic disease. Well, we don't know that. And most people probably recur. And so that's the key thing is, can we identify these patients by either selecting them through neoadjuvant, maybe treating their occult metastases with chemotherapy, and then withholding an operation that was unlikely to be of benefit. Now, we used to tolerate a positive margin in about a third of patients with upfront surgery. That's just what we did. Why? Because what was our comparator? Our comparator was a bypass. So yeah, a positive margin operation was better than a bypass. That is no longer our comparator. Our comparator now is chemotherapy followed by chemoradiation. What are the outcomes for patients with locally advanced cancer in 2021 who just get chemo and chemoradiation? Well, the data would suggest that's about 20 to 24 months survival median without surgery. So, boy, if that's as good as an upfront operation, what would you rather have? I'd rather have chemo and radiation than undergo a Whipple with all the other problems. So therefore, the comparator has changed. So now we need to say, well, what does adding an operation at the end of modern chemotherapy and radiation add to these patients' outcome? And that's where I think we're going to be pushing the envelope. Now, some people may say, well, you give adjuvant chemotherapy, and they'll talk about the new PRODIGE trial, which showed really remarkable survival in patients who received adjuvant FOLFIRINOX. Now, that adjuvant trial was very different from all the previous adjuvant trials because they enrolled patients after surgery, and they only enrolled people who recovered without a complication. So they already picked the best, performance status patients. And they also only enrolled patients who had a low CA19-9. So they picked the best biology. That's why even in the gemcitabine arm, those patients did very well. So it's a very select group of people. I don't know, my patients personally would probably not tolerate 6 months of FOLFIRINOX after a Whipple. That's just hard for me to imagine. It's hard for them to get 6 months of FOLFIRINOX prior to surgery. Now they're going to somehow do it afterwards. So I think there's a growing trend to give neoadjuvant to all patients, regardless of their anatomical resectability. It just logically makes sense. Now, are there some patients who I will operate on upfront? Absolutely. That would be the young, healthy, fit patient who's got a tumor in the body of the pancreas. It's less than 2 centimeters. It would only require a distal. Tumor markers are low. KRAS is low. You know, the PET isn't particularly avid. In those patients, I don't see any real benefit to giving upfront neoadjuvant. They'd probably be just as well undergoing a nice laparoscopic or robotic distal pancreatectomy and getting them on to adjuvant chemotherapy. But that's my personal bias.
Pues muchas gracias, Dr. Truty. Como siempre.
Thank you very much, Dr. Truty. Like always, your talks are very good, very, very down to the point, points of view, and always new ideas, different to what we see usually. I thank you both for being here. I hope to have you again in a different Congress here at the Mexican Society of Liver and Pancreatic Cancer. So thank you for being here.